A brief note on pulmonary aspergillosis, thoracic master class. Introduction. Aspergillus species are widely in the environment and are commonly isolated from both the outdoor environment and indoor environment, including hospitals. Pulmonary disease is caused mainly by Aspergillus fumigatus and has a spectrum of clinical syndromes. The sequelae of inhalation of Aspergillus spores depend on host immunity. So in normal hosts, there is no sequelae. In immunocompromised hosts, invasive pulmonary aspergillosis will result. In chronic lung disease, this will lead to chronic necrotizing aspergillosis. In patients with asthma, atopy, or fibrosis, allergic bronchopulmonary aspergillosis will occur. In cavitary lung lesions, we expect aspergilloma. Aspergilloma, or fungal bowl, is the most common form of pulmonary involvement by Aspergillus species, and it usually develops in a pre-existing cavity in the lungs. Mainly cavitary lung disease are complicated by Aspergilloma, and this includes tuberculosis, sarcoidosis, bronchiectasis, bronchial cysts, and bully, ankylosing spondylitis, neoplasm, and pulmonary infections. Presentation may vary from asymptomatic or symptomatic with hemoptysis characterized by being mild or recurrent or massive. Cough and shortness of breath due to underlying lung disease, fever due to superinfection. The diagnosis of pulmonary aspergilloma is usually based on clinical findings, radiological features, serological examination, and microbiological examination, with sputum culture being positive in 50% of cases. Normal chest X-ray is useful in demonstrating the presence of a mass in a pre-existing cavity. Aspergilloma appears as an upper lobe mobile intracavitary mass with an air crescent in the periphery. A change in position of the fungal bowl after moving the patient from supine to prone is an interesting but variable sign. Chest CT scan necessary to visualize aspergilloma that is not apparent on chest radiograph. This radiographic appearance may be seen in other conditions such as neoplasm, abscess, hydatid cyst, and granulomatosis with polyangiitis, the so-called Wegener's granulomatosis. The summary of treatment of a fungal bowl can revolve around medical treatment, intervention radiology with bronchial artery embolization in patients with hemoptysis, and surgical intervention, which may entail lung-sparing resections, global resection, cavernostomy with or without muscle flap, and with or without thoracoplasty in 1 or 2 stages. Lobectomy is considered the standard radical management as long as it is confined to a lobe, which in some cases is a site of tuberculosis or bronchiectasis. Pneumonectomy, on the other hand, is indicated if the affected lobe has been totally destroyed and the remaining lobes is severely fibrotic and small, and in the operation, the estimation of lung expansion will be impossible or difficult. Lesser resections in the form of wedge segmented resection aiming at parenchymal sparing has been suggested by some surgeons, yet others adopted lobectomy to avoid relapses and complications. Cavernostomy with or without myoplasty may be an alternative technique to prevent the recurrence of the disease and to reduce operative complications in patients with poor general conditions. The success of this technique depends on the closure of the bronchial fistula, adequate drainage, intracavitary fungal distillation, and an obliterated sterile space from a muscle flap with an efficient blood supply. Due to the difficulty in obtaining a really clean cavity, we don't suggest surgeon performing cavernostomy plus myoplasty in a single stage. Due to the severely ill patient, the underlying lung pathologies, and moreover low volume centers or inexperienced hand, major complications may arise, particularly bleeding from adhesions, empyemas, prolonged air leaks, residual pleural space, and bronchopleural fistula. For that, we recommend irrigation with amphotericin B and neomycin at the space, and as long as there is a longer need for chest drainage. Additional surgical procedure such as pleural tent, partial thoracoplasty may be used to avoid prolonged air leak or residual spaces. And to avoid bronchopleural fistula, aggressive peribronchial extensive dissection should be avoided by all means, and lymph nodes should be not dissected at the bronchial stump, and the bronchial stump should be reinforced with local pleural tissue, pericardial fat, or intercostal muscle flaps. In general, antifungal therapy for aspergilloma shows limited response, and the prediction of life-threatening hemoptysis is not possible. Hence, surgical resection is justified whenever the general condition and pulmonary functions permits. There is no consensus on the best treatment approach, whether inhalational, intracavitary, and intobronchial instillation of antifungal agents has been tried and reported in a small number of patients. CT-guided percutaneous administration of amphotericin B can be effective for aspergilloma, especially in patients with massive hemoptysis, and can lead to resolution within few days. The role of intravenous amphotericin B is uncertain. Small studies failed to show any benefit. Itraconazole may be useful in the management of selected patients with aspergilloma because it has a high tissue penetration. Oral itraconazole has been used with radiographic and symptomatic improvement in 2/3 to half of the patients. Occasionally, patients have a complete response.